I want to thank everybody for coming. This is our second time doing this, and so we're trying to get out a lot of information to everyone out there about the realities of lung cancer screening, because in the past several years, you've heard a lot of mixed messages, and now finally the definitive studies have been out. And I want to tell you a little bit about lung cancer screening, about what's happened. But as a patient, someone who's sitting here in the audience who's concerned about lung cancer, I want to tell you what you need to know about lung cancer. Why do you need to know anything about lung cancer? Well, lung cancer is the #1 cancer killer in the United States, period. It kills more people than colon cancer, breast cancer, any other cancer. It is the #1 killer. When you look at the incidence of lung cancer since the mid-1970s, you'll see that there was a 4-to-1 ratio of men to women. Then over time, the ratios become 1-to-1. So over the next several decades, more women developed lung cancer. Is it because of the ads out there that show a glamorous woman smoking? Is it because of the way it's been portrayed in movies, etc.? For whatever the reason, lung cancer in women has quadrupled to the point where it's almost the same between men and women. So it's important to know that not only lung cancer kills more than any other cancer, but lung cancer is a woman's disease. It kills more women than breast, ovarian, and uterine cancers combined. Yet you hear all these runs for breast cancer, for women's diseases, and they never have lung cancer in there. It's because there's a stigma associated with the disease. And remember, 15% of people who have lung cancer never smoked. So it's important to realize when they talk about women's diseases, they leave out the #1 cancer killer, which is lung. So there are about 225,000 cases a year. And I just got to teach you a little bit about the anatomy of the chest so you can understand what we're thinking about when we're looking at patients who have a potential for having this bad cancer. And the anatomy is all about lobes and nodes. So you have your right lung and your left lung. On your right lung, you have 3 lobes, upper, middle, and lower. On the left, you have 2 lobes, the upper and the lower. When you look at this, there are green things here, these green nodules. Those are called lymph nodes. What are lymph nodes? Lymph nodes are like your tonsils. When you get a cold, when you get an infection, they get bigger. Also, those are one of the areas that cancer likes to go to. So when you have a cancer that forms in your lung, the first place it usually likes to go is to the lymph nodes. And so it's important when thinking about lung cancer and staging, where is the tumor? How big is the tumor? And are the lymph nodes involved? Now, stage is based on size of tumor, whether or not you have lymph nodes involved, and whether or not the tumor has gone outside of the chest. In other words, metastasized. And why is staging important? Staging is important because you treat patients differently based on whether they're stage 1 or based on whether they're stage 4. And you use a combination of chemotherapy, surgery, and radiation depending on what your stage is. So this is an example of a stage 1 tumor. The tumor is in one spot here in the left upper lobe, and it's nowhere else. The lymph nodes aren't involved, etc. So that's stage 1. Most of those are treated by surgery. Stage 2 is when you have a tumor that's involved, and then you have the lymph nodes that have some cancer in it. That's considered stage 2, and that requires a little more, not just surgery, but usually you put some chemotherapy with it. And stage 3 is when you have lymph nodes that are involved, but that are far away from the tumor. So let's take this right-sided tumor. These are the lymph nodes that are close to the tumor. These are the lymph nodes that are far away from the tumor. So that bumps you up to stage 3. For those types of cancers, we do chemotherapy, surgery, and radiation. This is the staging system for lung cancer. It is extremely complicated, and that is not what you guys should look at. This is my staging system. So stage 1 is where you have tumor in one spot, and it's a small size without any lymph nodes involved. Stage 2 is where you have tumor with the lymph nodes close to the tumor that are involved. Stage 3 is where you have the tumor and the lymph nodes close to the windpipe, far away from where the tumor is, are involved, and that's stage 3. Stage 4 is where it has spread outside of the chest. So why is that important? Because the stage dictates treatment. So stage 1, surgery alone. Stage 2, surgery and chemotherapy. Stage 3, chemotherapy, surgery, and then radiation to the area that you can't take out. Now, it's really that simple. It's not any more complicated than that. Now, when you go to see a doctor, they may, work on different little things that can fine-tune your care, but that's basically it. So let's say, for an example, someone has a tumor. It's small, it's about 1 centimeter. It's in one part of the lung, and there are no lymph nodes involved. What's the treatment for that patient? Surgery. See? So you guys know exactly what I have in my head. See, as doctors, we try and confuse you. We try and use these big words and use these fancy terminology, so you say, wow, I don't understand what he said, but he must be smart. But most of the stuff that we use are very simple, and simple things that you can understand. But we use these big words because it makes us feel good. So for lung cancer, whenever you're dealing with any cancer, you look at 5-year survival. And here you have prostate cancer, breast cancer, and lung cancer. And when you look at the 5-year survival rates for prostate cancer, 100%. And this is from the American Cancer Society, so this has to be good, right? Breast cancer, 89%. Lung cancer, 5-year survival, 16%. Now, for those of you in the audience who say, wait, I have a lung cancer, is that how bad I am? No, that's for everybody. That includes stage 1, stage 2, stage 3, stage 4. So you have to look at your individual case before you start jumping to any kind of conclusions. But 16% 5-year survival, that's horrible. Why is that? For breast cancer, you have screening. You can palpate the breast. You can feel a nodule there. And you have mammography. Prostate, when you do an exam, you can feel the prostate. You can feel if it's hard, if it's suspicious. Lung cancer, or for a lung exam, you can't do anything. And that's why you need something to look inside of the chest so you can find out if there is anything growing in there. And for the longest time, CAT scans of the lung were not routine. And chest x-rays don't give you the whole picture. So another important figure from the American Cancer Society is what is the percent of cancers diagnosed before they spread? In other words, what are the cancers diagnosed at an early stage when you can cure them? For prostate cancer, 90%. For breast cancer, 60%. Maybe that's why their 5-year survivals are so long. Lung cancer, only 16% are identified before they've spread outside the chest. Does that number look familiar? Have you seen that number before? Yep, you saw it right here. So it's not a coincidence that if you catch the cancer early, that there's more of a chance of curing it. I mean, those are identical numbers, 16% here, 16% there. So we have a cure for lung cancer. It's called surgery. The problem is we're not finding it early enough. So the types of surgery that you can do is a wedge resection where you take a pizza pie-shaped portion of the lung. It takes a few minutes. It's not a big surgery. The other one is a lobectomy where you take out one of the lobes, and then the other one is a pneumonectomy where you take out the whole lung. So here you have, and the type of operation usually depends on the size of the tumor and the location. So here you have a tumor in the right middle lobe, and you can cut that out with the wedge resection. This is in the middle of the lobe, and you need to do a lobectomy. This is in this location, which is called the hilum, and you need to cut the lung here, and that's called a pneumonectomy. Now, why not just get x-rays? And I touched on that before, but there was a lot of debate and a lot of controversy with screening for many years. Very heated debates, and I'll go through this a little bit with you. So this is an x-ray of somebody with lung cancer. Can you see the cancer over here? This is your heart, this is your diaphragm, and then you've got the ribs over here. Can all of you see that cancer there? Right, so when you catch a cancer like this, it's usually a little more advanced. You usually get a PET scan to make sure it's not anywhere else. But usually when it's in a size that you can see it on x-ray, it has probably gone somewhere else. It has probably gotten outside the chest. Even though I do think that you can find many cancers with x-rays, but you can find more with CAT scans. So you find this type of cancer here, and then in the old days, we'd make this big incision, take out a rib, put in these two big retractors, and open up your chest. It's very painful. And the biggest argument was that if you got in there and you found something and it turned out not to be a cancer, then they just went through this whole big operation for nothing. So I do understand in the old days how they were big against screening. I can see that. Even though when I look at the data, I do think chest x-ray screening does help. But that's for another story. Now, here's a chest x-ray of another lung cancer. Do you see the lung cancer? No. I don't see it. There it is right here. So it's this little guy just sitting there. It's on the outside part of the lung. Something like that that's caught early, that hasn't gone anywhere else, is curable. So you can do this thing called a wedge resection, where you make 3 small holes. It's something called VATS, video-assisted thoracic surgery. And it's one of the most simplest surgeries you can do. As a surgeon, I try and justify my existence and say, oh yeah, I do this big complicated surgery, but this surgery, medical students can do it. So here it is, here's the tumor, one stapler that way, another stapler that way, and it's out. And most of those patients will be cured. So doesn't it make sense to find the tumor early, use this VATS procedure, because you don't need to take out a rib, crack their ribs open. It's painless, and they usually go home the next day. So it makes sense. Find the tumor early and get rid of it with a small procedure, right? But like Yogi Berra said, common sense ain't too common. And especially in medicine, we always need a lot of data to prove what we are doing. So back in 1999, Claudia Henschke, who was the pioneer of this whole CT screening, came up with a study that was in the New York Times, and I think that's more important than the medical journal it was in, and that got blasted all over the planet. And that showed that she found 23 with early stage cancer. So of all the cancers they found 85% at an early stage. You remember that figure I showed you? How many do they find at an early stage for lung cancer right now? 16%. So now she showed you can find 85%. Wouldn't you think that most of those patients could be cured? Right? So they said, oh, the study's not long enough, we need some more data. So what happened in 2006, she did a follow-up study. 10-year survival, 88%. So if you catch it early, most of those patients will live. And how many had stage 1? Again, 85%. So out of 31,000 screened, she found that 85% had stage 1 and 88% lived 10 years or more. So that shows you catch it early, you can cure it. But it's the customary fate of new truths to begin as heresy. So in medicine, right away, we're quick to say, oh, that doesn't work. For this reason, you got a false positive result. So what's the definition? Because in medicine, like I said, we try and make ourselves seem smart. So what's the definition of an intellectual? An intellectual is someone who takes something simple and makes it complicated. Right? What's the definition of a genius? A genius is someone who takes something complicated and makes it simple, and that's Dr. Henschke. So basically, in 2011, the National Cancer Institute put together this huge study to prove Dr. Henschke's work wrong. And what did the intellectuals find? They found that she was actually right. They did everything they could in their power to make this study show that her work was wrong. So they randomized, meaning they just took patients and they put them in each group by random selection. 53,000 patients, half got x-ray, half got CAT scan. And over a short period of time, they demonstrated a 20% decrease in mortality. And now you get into little nuances with medical terminology, but basically that is the minimum number. We actually think that that number should be higher, 60, 70, even 80%. But I don't want to get into that right now. Basically, this difference was so large that they stopped the study because it was not ethical not to offer the other group CAT scan. So they stopped it prematurely. So, #1 cancer killer in the United States, lung cancer. More than prostate, pancreas, breast, colon. And what's the goal of what we're doing here today? We're trying to educate the patient population out there, because there are many other institutions or individuals who disagree with this. And I think it's going to be open for debate afterwards, and we will welcome any questions of anyone who disagrees with this type of philosophy. And basically what we are trying to do is we want to try and cut lung cancer deaths by half by the year 2020. So we can realistically cut that in half by screening. How do we do that? We have a whole team in place. Dr. Henschke is leading the pack in diagnostic radiology, and I'll go through what each of these people do. So Dr. Henschke is the one who started it all. She's like the Vince McMahon of wrestling. She started the whole screening thing, right? She's got the largest database with 70,000 patients, and it is ongoing. The study that I showed you by the National Cancer Institute, that's it. It stopped. They can't learn anything more from that. But not only does it show cancer, but it shows emphysema, it shows cardiac disease, so it can show a lot of things. Over about 70 institutions now from all kinds of, countries all over the world, and she has basically written the book on everything that has to do with screening. So now with this new study, they're trying to reinvent the wheel, but she couldn't do it on her own, and she had her partner in crime, David Yankelevitz, who's also a co-founder, also someone who has a very unique skill set. He takes needles and he puts them into these little nodules so that you don't have to have surgery to figure out if you have a cancer or not. And what's amazing is people who come from all over just to have him take this needle and put it into their lung. So if you have something this small, like this little ditzel over here, this actually turned out to be a cancer. He comes in and he puts the needle in there and he gets it. And most of the time, he gets it. And that's a very unique skill set to have. Here we also have Paolo Buffetta, who's written a lot about the worldwide experience when it comes to lung cancer. So along with the ILCAP group that Dr. Henschke heads, we have Dr. Buffetta, who has all these other sites. And why is that important? It's important because when you do clinical trials, let's say if you use one hospital, it'll take a long time to get it done. But let's say you have 100 hospitals. In one day, you can enroll one patient in each hospital. So in one day, you can get 100 patients like that. And so you get the answer quicker, and you can take care of patients at an earlier time. Then you have Charles Powell from pulmonary. There's a lot of other pulmonologists that are just as good. You have Tim Harkin. You got all kinds of doctors that are part of the team to identify cancer and to help cure you. Then you have Dr. Rosenzweig and Dr. Andrews who gives the radiation many times for patients who are not surgical candidates. And here you can see in this slide how someone had this, and then little by little the radiation took care of it. Doesn't work in every case, but that is a possibility with radiation treatment. Dr. Gomez from medical oncology, basically he tries to personalize it. He sends all these cancers for special tests so they can figure out, okay, you have this mutation, you're better off taking this pill, which has less side effects than doing the heavy-duty chemotherapy. So every person has a role, and we all have the same goal. Our goal is to cut lung cancer deaths by half by the year 2020. And how do we do it? We do it with the screening programs. We also put on courses where we teach doctors how to do this, patient education, and I think that's the biggest one because it's really the patients who want to drive this. It's really the patients who are the ones that have smoked, who feel like, listen, I did something active to hurt myself in the past, and I want to make sure that I'm doing whatever I can to make sure that I can take care of this. Clinical trials, and that's the importance of the whole big network. And basically, we just want to stop as many deaths as possible. So in conclusion, the take-home message is CAT scan can detect early lung cancer. And when you detect it early, surgery can cure you. Our goal is to make sure that we educate the community on screening and using this whole worldwide network to help improve studies so that we can make further advances and really fine-tune the benefits that you get from lung cancer screening. Thank you.